is entitled Improving Dementia Care for Patients and Caregivers, and we'll hear about UCLA's program to provide comprehensive patient-centered care for people with various forms of dementia and their caregivers. We are joined today by Leslie Evertson, a dementia care manager at the David Geffen School of Medicine at UCLA, and David B. Rubin, Archstone professor and chief of geriatrics there as well. So just before we begin, just a couple of housekeeping items. The session will be recorded, and we will have the slides. People often ask if the slides will be available. So the slides and the recording will be posted on the CIN website within about a week, which you can see there, the website there listed on this slide. We have, if you can see on your screen, there's a few poll questions. Just if participants in the webinar wouldn't mind taking just a minute to answer some of those questions, it just gives us a sense of who's in the audience and what types of people are listening in on the webinars, and gives the speakers too a better sense of who's in the audience. If people have questions throughout the webinar, you can use the chat function to ask questions. If it's a logistical question, you can just send it to the host, and if it's questions for the speakers, you can actually use the chat function and set it to all participants so that people can see what types of questions are being asked. So the presentation today will take about 40 minutes, so we'll have plenty of time for Q&A. And just wanted, before handing off to Dr. Rubin, to begin the presentation, just wanted to introduce the two of them. So Dr. Rubin is the director of the multi-campus program in geriatrics medicines and gerontology, chief of division of geriatrics at UCLA, Center for Health Sciences. He's the Archstone Foundation Chair and Professor at the David Geffen School of Medicine at UCLA and Director of the UCLA Claude D. Pepper Older Americans Independent Center and the UCLA Alzheimer's and Dementia Care Program. He sustains professional interest in clinical care, education, research, and administrative aspects of geriatrics, maintaining a clinical primary care practice of frail older persons, and attending on inpatient and geriatric psychiatry units at UCLA. He's won 7 awards for excellence in teaching. His current research interests include redesigning the office visit to improve healthcare quality and measurement of how older adults function. And his bibliography includes more than 190 peer-reviewed publications in medical journals, 33 books, and numerous chapters. And he's the lead author of the widely distributed book, Geriatrics at Your Fingertips. He's also the past president of the American Geriatric Society and the Association of Directors of Geriatric Academic Advisors. And in addition to his leadership in geriatrics, Dr. Rubin continues to provide primary care for frail older persons and making house calls. And we'll also hear today from Leslie Evertson, who's a dementia care manager at the program. So Leslie graduated from California State University, Sonoma with a BS degree in nursing, certificate in gerontology, and minor in biology in 1998. She worked as a registered nurse in a variety of specialties, including bone marrow transplant, medical, surgical oncology, and intensive care. She graduated from University of Colorado at Colorado Springs, Bethel College of Nursing and Health Sciences in December of 2005 with a Master of Science in Nursing as an adult geriatric nurse practitioner and forensic clinical nurse specialist. And she also is the care manager geriatric nurse practitioner with the Alzheimer's and Dementia Care Program. And she's married and has 2 children and currently lives in Simi, if I'm pronouncing that correctly, Valley, California. So with that, I will hand it over to Dr. Rubin to begin today's presentation.
So have you handed it? Oh, it's being handed over. Okay.
There you go.
Well, welcome. I'm delighted to be actually presenting this because there's almost nothing I'd rather talk about more than the UCLA Alzheimer's and Dementia Care program. So I'm representing a team of people, and as well as Leslie, and it really is a team effort. And get started. First of all, I have to give a couple of disclaimers. The first from CMMI, which is part of CMS Medicare, and they've funded us through an Innovations Challenge Award to rapidly disseminate this program, and also for the Pepper Center, who has provided some infrastructure support for the program. What we're going to cover, first of all, is background. We'll talk about the program. I'll present some of the first-year findings, some challenges we have had to face that other healthcare organizations would also have to face in implementing such a program, and then we'll talk a little bit about the future. So I like to call Alzheimer's and dementia the Great Plague. It's a disease that everybody I speak to will experience at some point in their life. If it's not them developing the disease, it will be their spouse or their parents or their uncles or their friends. Currently, it's an age-related disease that in younger, older people, 65 to 74, it's very uncommon. But by the time people reach 85 years of age or older, roughly half of the population is affected. Currently, about 5.5 million Americans have Alzheimer's disease. And the big problem is the quality of care for patients with Alzheimer's disease and other dementias. And a number of studies that have been conducted, some of which we've been involved with, that the overall quality of care for this is less than 50%. The kinds of things that aren't being done, if somebody fails a cognitive screen, doing a full mental status examination only happens a quarter of the time. Checking medications to see if some of the medicines may be causing some of the cognitive decline, less than 10%. Providing caregiver support, less than a third. Monitoring for behavioral and psychological complications, less than a half. Moreover, there are poor linkages to community-based resources that might be able to help. So why is this the case? First, busy practitioners don't have enough time. And this is a study that was conducted almost a decade ago, and it assumed a practice size of 2,500 patients, which was thought to be the average practice size of a family physician. It may not be quite accurate, but it's close enough. And it assumed that the physician would be caring for a nationalized age and chronic disease distribution. And looking only at the following guidelines for 10 chronic disease, it would take the physician 10.6 hours per day. And that doesn't even begin to address the chief complaint of the patient. So when doctors say that they don't have enough time to do all this chronic disease management, they are actually accurate. The second is actually kind of a unique situation, perhaps to Alzheimer's and dementia, is that in a sense for a busy practicing physician, it may be too rare. So if you assume a patient panel of 2,000, an average family physician or general practitioner will have about 300 patients who are 65 years of age or older. About 150 of those will have 3 chronic conditions, and almost 200 will have musculoskeletal pain. About 45 will have cognitive impairment, and half of those roughly will have dementia. But only about a third of demented patients are recognized as having dementia. So if you have 8 patients in your practice who have dementia and you're trying to provide good care, frankly, you don't see it often enough to manage it well. You don't know the community resources. You may not be able to keep up with the literature. So this is kind of bad news for the healthcare system. Dementia costs in 2011 $130 billion in healthcare. People with dementia have 3 times as many hospital stays, higher medical provider, nursing home, home health, and prescription drug costs. And that doesn't even count the caregiving that the friends and family provide, which is estimated in 2010 as being worth about $203 billion of uncompensated time. So here at UCLA, we have terrific programs in geriatrics and geriatric psychiatry, dementia research. We're well known for all of this. But we've had virtually no caregiver support. And there have been great programs in the community, but we've had really no formal linkages. And as a result, patients, even at a place like UCLA who have dementia, fall through the cracks. So this program got started, and I think the story is interesting, but also illustrative. It really started from a grateful patient, so one of my partner's patients whose wife had dementia. And the interesting thing about this story is that he was exceptionally wealthy, had full-time caregivers, and in spite of having that kind of wealth and that kind of support, things were getting dropped or things were arising. So at 5 o'clock in the afternoon, when his caregivers had to leave for a family emergency, he was caught with a problem of nobody being able to care for his wife. There were all sorts of legal and financial challenges that they had to work through in terms of paperwork. And every time he would come across one of these challenges, he would call me, because I'm the chief of the division, and see if I could get this unstuck. So we figured that if, in fact, somebody who had all of his means couldn't get the system to work for a patient with dementia, think about people who didn't have that kind of means. So his wife, as I mentioned, had dementia. She was getting very frail. He wanted to do something for us. And so we proposed to him to try to do something for people like his wife. And we did some homework and came across a program that had been developed at Indiana University that we thought was quite innovative and quite comprehensive. I'll tell you more about that. Right around this time, this was in 2011, I got a phone call from a woman named Patty Davis. And Patty is President Reagan's daughter. And she told me that she had been thinking a lot about her dad and wanted to try to do something for family members of patients who had dementia and Alzheimer's disease, and was interested in starting up support groups. And although she didn't want to do this pro bono, it was very helpful in terms of gaining institutional support. Our hospital happens to be named for her father, and having her come in with us was very helpful in terms of getting some buy-in from the senior leadership. And we went through a step of actually going through to get institutional leadership, not only from the medical center, but from the departments. And as I mentioned earlier, there are a lot of competing programs that do dementia and Alzheimer's, including in psychiatry, geriatric psychiatry, medicine, neurology. And basically, each of these has their own niche, but no one program was interested in providing comprehensive care of patients. So we spent a lot of time, and still spend a lot of time, selling the program and what its unique advantages are, so that different programs didn't feel that it was a competitor. Early on, it says we kissed a lot of frogs and found Prince Charming. The original patron of the program turned out did not have the means to put a lot of money into it, but put a small amount to get us started, and introduced us to a number of people, as did Patty, who might be able to get the program off the ground. And it turns out that one of the friends of the original patient was willing to put a lead gift to the program that got us started. And so we were more than just being an idea. We were at least something that was on paper. Around the same time, this was in early 2012, we submitted a CMMI Innovations Challenge Award to try to take a program that was just beginning and expand it out to as many people as possible. We were very fortunate. We were one of the first 26 that were announced, and one of the first 120 or so that were funded to do this project. And then came the hard work of implementation, and I'll tell you a little bit more about this in a few moments. So the UCLA Alzheimer's and Dementia Care Program is based in part on the model developed at Indiana University. And that program is kind of unique in that it serves an indigent safety net population. It's through a county hospital system, essentially. But the program, which a lot of the core elements we'll tell you about in just a moment, reduced behavioral symptoms and caregiver stress by about half at 12 months. And at least preliminary data showed that it reduced emergency department visits, hospitalizations, and 30-day readmissions by about half. The linchpin of that program and our program is a dementia care manager who, in our model, is a nurse practitioner whose role is to tailor and facilitate all of the delivery components. So it works with physicians to care for patients by providing in-person needs assessments, developing and implementing individual care plans, monitoring response and revising, and providing 24/7 access. Important to realize this is a co-management model. The dementia care program does not assume primary care, and in an environment like UCLA's where primary care physicians are very engaged with their patients, we could not establish a program that would be thought of as stealing patients. We are just in a very competitive environment here. So I'm going to let me just introduce the team. We currently have 3 dementia care managers: Leslie, who will speak to you in just a moment, Kimmy Reeves, who's in the middle and the top, and Michelle Panlilio. We are recruiting a 4th dementia care manager. In fact, I'm trying to get a hold of somebody today to offer them the position. I'm there in the lower left-hand corner. Zaldi Tan, who's a superstar, is our medical director, and Catherine Serrano is our secret weapon who administers the program, and Tia Fernandez, who's not pictured, is our patient services representative. So I'm going to, one more slide, in terms of how do people get into the program. Patients are mostly referred by their physicians. We've done a lot of marketing efforts. We've gone to practice after practice to tell them about the program. And these are patients who by and large, these physicians have had some trouble caring for. They spend a lot of time on the phone with them. They spend a lot of time coordinating care, and it's been very difficult. So by and large, they've been very willing to refer to us. We're also able to identify people with diagnoses of Alzheimer's or other dementias through our electronic health record, both from inpatient diagnoses and more increasingly now as we've switched over to an Epic-based system to outpatient as well. One of the conditions is they must have a referring physician to whom recommendations can be conveyed. As I mentioned earlier, it is a co-management model. So we have to have a physician who we can partner with. And now I am going to turn this over to Leslie, who will tell you about the nuts and bolts of the program.
All right. Thank you, Dr. Rubin. And thank you for having me today. So I want to tell you a little bit about what we do once we get a referral. So as Dr. Rubin mentioned, most of our patients are referred by physicians. We have a few that self-refer. We have a process for that, and some of them that we actively seek based on billing code. But once we get this patient and we've confirmed that they do have a diagnosis of dementia, we send the patient and family member pre-visit information. Now that's a pre-visit questionnaire and some standardized instruments to screen things like caregiver stress and functional dependency. We schedule a 90-minute visit in office with myself or one of the other dementia care managers. The patient obviously comes and it is mandatory that a legal decision maker, which is usually the family caregiver, is present with the patient. I have had as little as 2 people come and as many as 10 to a meeting. It just kind of depends on the dynamic, and I know those of you that work with dementia patients can appreciate that. During the 90-minute visit, we go over what this particular family and patient needs, what their needs are, and what resources they have. Resources for us are not only monetary, but it's maybe which family members are able to help, what kind of living situation are they in, and then we also look at things like, are they a veteran? Do they have long-term care insurance? Do they have savings? What is the plan for this patient? As a nurse practitioner, I have a CoManagement Model in any case, so I'm supervised by our geriatrician medical director, Dr. Zaldi Tan, as Dr. Rubin mentioned, and he's available for weekly meetings where we essentially do an interdisciplinary round and we go over patient cases. He's also available as needed. I put my recommendations on paper, which end up being something very similar to a comprehensive medical history and physical with a nursing care plan mixed with a little social worker assessment. I send the summary to the referring physician for approval. And then once I have the approval, I go ahead and I contact the family. So what does the family get from me? During the visit, we do spend a lot of time talking about what they already know and what to expect. And I get patients, you know, the first week they get the diagnosis to late-stage patients. So I meet them where they're at and not only educate the patient if that's feasible, I also educate the family. And in the case of where we live, we found we also have a lot of paid caregivers that become like family, live-in caregivers, and we take a lot of time to honor their observations and how this is affecting them as well, because they really are part of the care system and part of that patient's resource as well. I take time to recommend UCLA programs that might be applicable to them. Things like our support groups, which we offer to everybody where that is geographically feasible, because they are located in Santa Monica, and we see patients all over the greater Los Angeles area. There's educational lecture programs through UCLA. We also, I think as Dr. Rubin mentioned earlier, can get them in touch with the Easton Center, which is the Alzheimer's Research Center here at UCLA. We have formal partnerships with many community-based organizations that I will touch on in a little bit, and they all have their own specialties. Some of them have adult day, some of them are support group focused, education, counseling, homebound meal delivery, case management, and my job is to kind of cut through the fog of this and really point out what I think would work for these often stressed family caregivers and patients. And I try to do the turnaround within a week or two. Once we write the note and we review the medical record, sometimes we do wait a day or two for the referring physicians to get back to us with the approval of our care plan. And then we contact the patient and family by email and or regular good old-fashioned postal service, depending on what they prefer. So what do the physicians get? They're going to get an email from me with my summary, as I mentioned. If there's any medical recommendations, say I recommend geropsychiatry consult or have you considered Aricept for this patient, the physician has the right of first refusal. So if I send that care plan, it's going to ask them, do you agree with this medical recommendation? Do you want me to go ahead and order it? Would you like to do it, or would you like some time to think about it, or don't agree with it? And we amend our care plan that we give to the patients accordingly, because it is, as Dr. Rubin mentioned, a co-management model, and we need that physician to be on board with our recommendations as much as they want us to be involved. So it is a two-way street. Whereas the behavioral and social recommendations, often education and social services, those are things I start implementing the day that I meet them. I put the entire note in the clinical record. Here we have an electronic medical record that is accessible by almost all of our referring physicians, save a few private practice docs, which we can fax the documentation to. I continue with coordination of care, so if they're in the process of getting further workup, being seen by other specialties, if they're enrolling in hospice, if they have issues with applying for assisted living or adult daycare, things like that, then we help with the forms and coordination of signatures and linking them with those resources. I do call as needed, and we have a system where we usually are calling again after the first care plan follow-up, about a month, so 1 to 2 weeks after the initial visit and then about a month afterwards, and then depending on where they're at, phone calls average between 1 and 3 months. Some patients and families are tech savvy and they prefer email follow-up, and we're happy to do that as well. So as I mentioned, UCLA has education series that they do online. There's webinars and videoed lectures that we have accessible on our website. I do ongoing medication adjustments as long as it's related to their dementia and behaviors. And if they have any urgent medical conditions, I'm sure to communicate that with the physician for some ongoing support. Every patient at the first visit, we do start talking about advanced care planning, review any advanced directives, durable power of attorneys for health care, and we start talking about a POLST form. I do recommend consultations if needed to any of the specialties, and as I mentioned before, to support groups including Patty Davis's Beyond Alzheimer's. At the Santa Monica campus here at UCLA, we're lucky enough to have a geriatric-specific med-surg unit, and we often will facilitate a admission to that unit so that they can be followed by our geriatricians as attendings. And although we try, sometimes we do have to facilitate an admission to the neuropsychiatric hospital. Sometimes it's for medication management and rapid titration, and sometimes it's because they have been 5150'd. In either case, we reach out to the attending psychiatrist and try to help with their care while they're in the hospital by giving some back history and reaching out to family, and also to be available for the transition and discharge. I also mentioned the Alzheimer's Disease Research Center, Mary Easton Center. We ask the patient and family at the time of the initial visit whether or not they'd like to be contacted by the Easton Center to learn more about clinical trials. I mentioned that we have community-based organizations that we formally partner with, and they're here on the screen. We have the Alzheimer's Association, the Southland chapter. Primarily, we get education, classes, support group, references, referrals from them, and I do use their care coordinators for regional specific questions in our area. Wise and Healthy Aging is located here in Santa Monica, and they're a large senior resource center that includes adult day, support groups, counseling, and case management, among many other things. They also have a large benefits enrollment center and financial and legal clinics. Opeka Adult Daycare and Caregiver Support Center is exactly as its name implies, a little smaller facility, but we use them quite a bit here close to us. Lisa's Place, also now known as Lisa's Care Connection, that's Lisa Gibbons Foundation, really the only community-based organization that is almost 100% for the caregiver, and we do draw upon their expertise at times as well, and Jewish Family Services. They are peppered all over the greater Los Angeles area, can offer things like support, case management, in-home meal delivery, things like that. So what do we rely on the community-based organizations for? Each one of the ones I mentioned earlier have a role on our steering committee, so they represent their organization and provide input on our program, and also hear our feedback at that time. As I mentioned, the different services that they provide, and each one of them kind of does something really well, and in some cases their services overlap, and we make a decision maybe based on cost or geography or patient preference. And one of the things we really are honing in on more so in the second year is really focusing on caregiver training. Things like Savvy Caregiver, Powerful Tools, those courses have been around for quite a while, but have, in their current format, require family members to leave their loved one oftentimes and go attend these classes. We found that was a little bit more difficult. Dr. Rubin will talk a little bit about how we've compromised on meeting our goal. We'll still meet it, but asking them to help us meet it, rather. Access. So our program is 24 hours a day, 7 days a week, 365 days a year. The dementia care managers work Monday through Friday, business hours, and nights, weekends, and holidays, the geriatricians and the practice go on call for us. The nice part about it is our notes are available for them to see within the computer, so that they hopefully will know what behaviors have been expected and normal for the patient and when there's a deviation. And also the intensity of care treatment wishes should be available for them as well. Depending on the nature of the call, they sometimes can handle it themselves, or they pass it off into the PCP to manage if necessary. As far as monitoring goes, all patients are seen in person by the dementia care manager at least annually. I occasionally see patients a little bit more frequently, depending on how the family caregiver and the patient likes to interact. Sometimes they prefer in-person meetings, and I've got a few families that I just see them quarterly. I have some caregivers that would like to set up monthly visits, and I see just the caregiver to talk about what's going on, and sometimes that has a lot to do with the inability to speak openly in front of their loved one at home. So they find the privacy of the office is a place where they can be really truthful and vent a little. And I reach out anytime I see the patient has been hospitalized or touched the ER here at UCLA. I have a follow-up call. If they're in the hospital, we go to visit them there and see what we can do to help the treating team. Right now, we're aiming for a panel size of about 250. We're all working towards that goal at the moment. It's a challenging number, but the thought is that with the usage of good partnerships with the community-based organizations, that can be an attainable goal. At this point, our current number includes patients who have passed. But as the program goes on and we have a couple more years under our belt, we'll see if this number rises or lowers. So, all right, and then I think the next slide is Dr. Rubin. Pass this to you.
Yeah, if you could transfer the control back to me. Great. So yeah. How did we get this thing up and running? And these are some organizational lessons here that we divided it up to 7 working groups to cover all the aspects. First, we had to set up an assessment, and that really focused mostly on what happens in that 90 minutes. What kind of information do we want to collect about needs, resources that people have? And we've created an assessment instrument that is actually available, and we're certainly glad to share. But it took a long time to do that. We wanted to make sure we had it right. The second is the software group, and I'll say more about this, but let me just introduce it by saying that we had hoped that our previous software at UCLA, or our now current software, which is an Epic-based system, would be able to do many of the functions to support this program, and it turns out it's just not the case, and I'll say more about that a little later. Outcomes committee to see if what we were doing was actually meeting the goals of the program, and I'll say a little bit about the outcomes in a bit. Community-based organizations. From the get-go, we've really had to work with them. It turns out that there have been some very loose affiliations with community-based organizations, but nothing really formal, and this has really formalized it. And it's been a great two-way conversation between the leaders of these organizations and our program. Communication referrals is really about communicating with doctors, how they like to be communicated, and some of the things that Leslie said in terms of methods are things that we really had to work out. Development relates to keeping the program going and getting initial funding to keep it to get it up and running. We'll talk a little bit about that later on. And finally, media and marketing. And this is kind of the silent committee, because you take this kind of thing for granted, but in fact, this is a way in which the medical center really helped us out a lot. They've had media people who have helped with press releases, getting us into newspapers and into radio and television media so that people are aware of this program, and also created marketing materials. I can't say how important having a glossy flyer is about this program, but it's supposed to help patients identify what the value of this is, as well as their physicians. So how do we make this work? Currently, the model we're using is to bill for Medicare services that are face-to-face services. This is the same model that we use for any fee-for-service types of patients that we see. So that initial 90-minute visit, Leslie and the other dementia care managers bill for. They're nurse practitioners seeing patients independently, so they can get 85%. what Medicare will allow for a physician, and that brings in some money to support the program. We have set up what we like to call a Robin Hood model, where we take from the wealthy and give to those who aren't so wealthy. So one of the conditions has been all other services, all the other work that Leslie and the other dementia care managers do, we're not charging for. So all of this care coordination with primary care physicians and CBOs, the telephone follow-up, the support group, all the education, we're not charging at all for this. And so that does lead to, we have been seeking ongoing philanthropy. We have gotten gifts from people who have been grateful or who have been interested in the program that have been as low as $10 and as high as over $1 million. It turns out that many, many patients who and their families who are going through this disease or have gone through this disease have been incredibly grateful and have wanted to make the experience of others easier. I think it's a very reasonable program to try to raise funds for. Unfortunately, Alzheimer's and their dementias doesn't respect any kind of affluence boundaries. It affects the wealthy as well as the poor. So our planned evaluations, this relates to the outcomes groups. We're looking to achieve the triple aim that's been identified by CMS, better care, and that includes quality indicators. Some of the quality indicators that I said were so bad at the very beginning of the talk, we're looking at and trying to improve, as well as caregivers' rating of the care. So we're actually asking the patients and their proxies about the services we've provided. Better outcomes by and large are related to the patients in terms of fewer behavioral symptoms, so that they're less agitated, less aggressive, able to stay in their homes. And we've also regarded as very important the caregiver outcomes. Less stress, less depression, and I'll show you in a couple of minutes is that this has been a big issue. Lower healthcare utilization, including reducing emergency department visits and hospitalizations. It turns out we may be able to reduce these. We cannot eliminate them. And every time, as a person who's been very invested in the program, every time one of the patients gets admitted to the hospital, I cringe. But in fact, these people are sick and they're old, and they get admitted for other things like urinary tract infections and falls, et cetera. And so overall, we hope to reduce costs. When we submitted this to CMMI as a grant, we figured that if we had 1,000 people in the program, we could save Medicare about $6 million in costs. So let's talk about the first-year finding. We went live in July 2012, and these are data through June 2013. During that first year, we enrolled 307 people into the program. Their average age was almost 82. They were mostly women. And the most common diagnosis, as to be expected, was Alzheimer's disease, but many of them either had mixed or people were uncertain of what the specific cause of the dementia was. There are no biopsies. There are no special tests for this program. They just have to have a clinical diagnosis of dementia. So many times we don't know what form of dementia it is. We just know that it's dementia. The mean mental state exam score is 16.4. This is pretty low. Generally, the threshold they use for determining whether somebody has cognitive impairment is 24. Below 24, it fails the screen. So the average here was considerably less than that. The caregivers were about split between spouses and children. And so what did we do for these folks? About 77% we referred to support groups. We provided caregiver training for about 2/3. We referred about 2/3 to the Alzheimer's Association Safe Return Program in case there was wandering or people would get lost. We referred over half to community-based organizations for services that we felt that they provide better or less expensively. About a third had the medications adjusted, and that could include either discontinuing medicines that might cause cognitive impairment or starting medicines to try to maintain memory as long as possible or control behavioral symptoms. About a third of them were referred for additional evaluation. And I think particularly interesting here is that about a quarter of them completed post forms. It's very interesting. Many of these patients have never had discussions about end-of-life care and what people would want for in those situations. We found tremendously interesting information here that people were ready to have these discussions, but their physicians never had time to do it. We also surveyed for these patients the caregivers at baselines about what this program might do for them. And it turns out at baseline, only a third of patients had received advice about the dementia. These are the caregivers about dementia. And only less than 1 in 5 knew how to access community services. Less than a third felt confident in handling dementia care problems, but almost 80% felt that their regular doctor understands how memory or behavioral problems complicate other health conditions. But only 28% agreed that they had a healthcare professional who could help them work through the dementia. So we see this incredible dichotomy here of people thinking that their doctors were very sympathetic, they got the big picture, they understood what was going on, but less than a third agreed that they had somebody who could help them along this journey. So challenges. We have had challenges that have kept me up at night. One of the big ones is software. As I mentioned, we have transitioned to an Epic-based electronic health record. It turns out that Epic does not have a case management function, and we basically have had to engage a vendor to develop software that interacts with Epic and can receive data exported from Epic, but serves as case management function. Among those is telling the dementia care manager what her roles and responsibilities are that day, who she needs to follow up with, what quality indicators have been completed and what haven't. And it gives us an opportunity to see how we're doing both on an individual patient level, but also on a program level. It also allows us to communicate with patients and community-based organizations. So this software, once it's finally completed, which will be soon, we will actually be able to interact with community-based organizations electronically, and they can interact back with us to communicate recommendations and findings. It also, we need the software for generating reports and for research purposes to support the value of this program. And finally, we had to develop another software system for additional community resources. It turns out many of the folks on the call probably have used Angie's List, and Angie's List is very valuable. It really doesn't have anything for dementia. And in fact, many of our patients need community services. They need private agencies who can do things like home modifications or case management or things like that. And we have created an Angie's List type of software that allows people to post resources and evaluate them, similar to Angie's List. Another big challenge is dealing with physicians, how to communicate with them, and we had some struggles along the way here. We found that the best way to communicate with them now is an email or through the electronic health record, through their in-basket, giving them the recommendations. We've tailored this so that it's very easy. It doesn't take the doc more than a minute or two. It starts with the medical recommendations, which they can agree with, implement themselves, agree with, or have us implement them, or not agree with, or want to wait. And then we also communicate everything we've done for them that is a non-medical, all the social service referrals, all the caregiving support that we provided. Other challenges are multiple physicians who are caring for a patient. We've identified, we try to identify one person who is the communicating physician. Defining areas of responsibility, and this has been very physician idiosyncratic. Some want us to manage not only the dementia but other geriatric issues. Others want us to stick only to the dementia, and we've done a little bit of this on a physician-by-physician basis, but by and large our stance is that we manage the dementia and the others are pretty much the responsibility of the primary care physician. We've had issues who have relocated, patients who have relocated. They've moved to children who are outside of the area. They've gone into nursing homes, et cetera, and we've had to be able to make contact with, keep contact with them and continue to provide service, and that also can be challenging. We've had to deal with some hot-button issues such as driving. Driving is an amazingly important issue for patients with dementia. We are here in California, and the requirement is reporting by the physician who makes the diagnosis. So we do not do reporting ourselves. We work with the primary care physician to do reporting and give them advice about how to do so and can bring up the issue, but we don't do the reporting ourselves. Finally, adult protective services reporting. We always try to touch base with the primary care physician before we do that because they may have some information that we don't know. Another challenge has been engaging CBOs to perform optimally. Their financial model is very different. They tend to work with block grants, and for our purposes, that block grants really don't help us much. We need to hold them accountable. So we've established over the past year a voucher system where the dementia care managers can authorize services for them. Once service has been authorized, the CBO performs it and then invoices us, and we pay for the services, and that's worked out quite well. Caregiver and support and training, you think that if you offer it to people, they will take it, but in fact, this has been very challenging for us. Sometimes these caregivers can't get away from their family members to actually attend a support session or attend a caregiver education session. So we're increasingly using materials that can be done through an internet or websites. We are also developing what we're calling Caregiving 101, which is has two components. One is a standardized education component for caregivers, and the second is somewhat tailored to the specific problems that the patient is having. And this can all be done, the Caregiving 101 can all be done in the context of somebody's home. The final and big challenge is sustaining the program. We have philanthropic support to get us through the next few years and the CMMI Innovations Challenge, but we are going to have to think about how we can keep this going indefinitely, and I'll say more about that in a moment. So our goals is the full complement of staff. Hopefully we will hire very shortly our 4th dementia care manager, which will allow us to serve 1,000 patients. We hope to get to that by the summer sometime. We are currently at 476 patients that have been seen and are booking all the way into January. As I mentioned, having a financially viable business model is going to be exceptionally important. I think we might be able to sell this to some of the managed care organizations if it does in fact reduce costs. And Medicare through the ACA has the authority, if this program is successful, to implement this as a defined benefit under Medicare without having to go through Congress. So that doesn't mean they're going to do it, but they would have that flexibility. And our final goal is to really spread the program beyond UCLA, which is one of the major reasons for this call today, is that we think that we have developed a model that certainly our patients and the physicians who we've surveyed about this have thought has been terrific. They have just loved it. We think that we are providing a substantial benefit to them. And we've also created a lot of infrastructure and also materials that could help other institutions develop this, implement this much more quickly. For example, the assessment instruments, the patient education materials, all of this stuff we've spent hours and hours and hours developing. We've developed this software system that should be able to interact with other, certainly with any Epic-based program, but with other software programs as well. And so the many, many hours and years that we've spent trying to get this thing up and running, we think that it really could be implementable elsewhere and sustained as well. So at this point, I'm going to stop, and we have some time for questions. So, Lori, would you like me to hand the microphone back to you, or the pointer, the control back to you?
Sure, thanks. Well, thank you both so much for the presentation. It was a really interesting presentation. So just a couple of reminders to folks. We have a couple of poll questions that have been posted. If people could just take a couple moments to answer the questions, it's really great to get feedback on the webinars. And also if people have any questions for the presenters, if they would like to just submit them through the chat function. David, you were just speaking about the sustainability in the business model. Do you have any thoughts on? It sounds like you all are funded through philanthropy, and how do you have any thoughts, initial thoughts, on how this program might be sustained financially over the long haul for your program, but for other programs as well that might be considering a similar type of program?
So one of the things, certainly in managed care programs, managed care organizations, these are really high utilizers. These people cost about $43,000 a year. And if, in fact, this can save us some, a quarter of that, let's say a quarter of that, or even less than a quarter than that, then this program is actually self-sustaining. It's a budget-neutral type of program. And so it does, if you're going to sustain this in managed care where there's that kind of flexibility to divert resources to programs that are working, that would be one financial model. Certainly in accountable care organizations also, that there could be an investment in a program like this with the idea that there would be shared savings or other financial benefits. In fee-for-service, it's more difficult. In fee-for-service, it's more difficult. We estimate that about 25% of what a dementia care manager does is billable under current regulations, so that the care coordination, all the stuff that's done on the phone and through email, et cetera, currently is not reimbursable. Maybe at some point or another it will, but at the moment it's not. So in the short term, at least, this is something that's more difficult in getting this implemented and sustained in fee-for-service, which is the reason we're having to seek philanthropy.
Great, thanks. Unless there's any more questions, did you guys see any questions come through? If folks have any questions, they can post them through the chat function and send them out. David and Leslie, sometimes people send them directly to the presenters and we can't see them, so you might want to do a quick glance in your box to see if there's anything that came through.
I don't think so.
Okay, great.
I don't think so.
I wanted to thank you both for a great presentation, and just a reminder to people listening in, again, if they could take just a couple minutes to answer the questions before they sign off, and the slides and the recording will be available at the CIN website within a week. So thank you, thanks everyone for joining.
Thank you so much.